So, ladies and gentlemen, thank you for being here with us today in this 2013 Euro Ataxia and the Hellenic Friedrichs Ataxia Association conference that is been held for this year in Greece. So, on behalf of the Hellenic Friedrichs Ataxia Association and in collaboration with the Euro Ataxia, which I'd like to thank from the bottom of my heart, it's my pleasure to welcome you all to this conference. I'm Vasilis Karatsias, the president of the Hellenic Association. I have the honor to be also the vice president of Rare Disease Greece and a member of the board of Euro Ataxia. So we gather here today in this beautiful surrounding of Piraeus in Greece to explore the latest advancements and breakthroughs in the fields of ataxia research. I would like to extend my warmest gratitude to Andreas Natke, to Sue Millman from Ataxia UK and Euro Ataxia, actually the president and the secretary of Euro Ataxia, for the invaluable support and cooperation throughout the last 10 months while we were preparing this event for the ataxia community. I also want to express my appreciation to our esteemed session chairs, keynote speakers and presenters who have generously shared their expertise, and they will share their expertise and insight with us. Their contribution, your contribution, is undoubtedly shape the future of ataxia globally, ranging from diagnosis up to treatment and ultimately a cure. Our program today is filled with thought-provoking sessions highlighting a range of topics that are vital for our understanding as patient advocates and patient organizations of ataxia. We are going to hear from our esteemed speakers topics with regards to diagnosis, symptom alleviating treatments, and what it is ahead of us. So we will also hear from researchers about their groundbreaking work on animal and cell models and the perspectives of the individual living with ataxia. This conference provides an exceptional opportunity to engage with junior researchers also who are making significant contribution in the field. Their flash talks promise to inspire us all with their cutting-edge research and fresh perspectives. I would like to express my thanks to our sponsors for their generous support. Their dedication and commitment to advancing ataxia research are commendable. Without their contribution, this conference would not have been possible. I would like particularly to acknowledge the European Union's Horizon 2020 program and innovation program, especially the European Joint Programme on Rare Diseases for partially funding this event. Their support demonstrates the European Union's unwavering commitment to promoting scientific knowledge and improving the lives of individuals affected by rare diseases in general and ataxia in particular. In addition, we have the privilege of hearing from representatives of pharmaceutical companies later this evening with clinical programs. Their updates would shed some light on the latest developments in therapeutic interventions and give us hope for future breakthroughs. As we progress through this conference, I encourage each one of you to take profit of this great environment and cooperate with one another and make some personal connections, because at the end of the day, it is all about this. It is about creating a family of like-minded persons ranging from patient advocates to researchers and clinical doctors, because all of us, we have and share a same dream. A world that at some point in time will be free of this horrible disease that we are discussing today. So I want to welcome you in Greece and thank you for being here with us. Now I want to pass the floor to Andreas Natke, who is the president of Euro Ataxia. Thank you.
Good morning, everyone. Thank you, Vasilis, for these warm words. And I'm very happy to see you all here in person, since we have met 2019 in Sheffield, the last time before the COVID breakout, and we all have to meet through Zoom. So it's a really pleasure for me to see all in person, to have the chance for networking, for speeches, for nice evenings organized by Vasilis yesterday evening. Thank you so much. And first of all, I would like to thank Vasilis for this fantastic organization of this conference in this very beautiful place here in Greece. And it's an honor to be here. It's an honor to be your guest, the guest of the Hellenic Ataxia Foundation. And I also want to give a warm welcome to our Portuguese friends, just Luis and Carlos, hello, who have been attending Ataxia meetings through Zoom several times. I think it was 2 times. We met via Zoom, and it's the first time you attend the conference personally, so a very warm welcome. I'm happy to see you. I'm happy to get you know further, and I'd also like to thank our sponsors who generously support the conference. PDC Therapeutics, Bioheaven, Vico, Ardivis, and Ariti, who are supporting us for standing up this conference here in Greece. And it's an honor to be here. I'm very happy and looking forward to the next 2 days, looking forward to the dinners, to the conversations, and to get to know each other. So thank you for coming to Greece. And now I would like to hand over to Vasilis. Thank you so much, who is the chair of the current session.
So let's start our program, and I would kindly ask Professor Marios Hadjivasiliou, Professor Dr. York Schultz, Dr. Miriam Rai to take the seats in the... Dr. Boroni will be on line. He had there were some issues with her flight. So introducing Professor Hadjivasiliou is tricky, because he's not only an academic, he's not only a consultant neurologist, but he's a key person internationally, globally, that is dealing with ataxia the last 30 or more years. So it is a great honor to have you, Professor, with us today, not only for the associations that are present live here, but also for the members of Euroataxia that are watching us throughout Europe at this point in time. So thank you. Without further ado, the podium is yours.
Thank you very much, Vasily, and thank you for the invitation. And thank you to Sue and Emily, particularly also because she's kept us going. So I've been given this impossible task to talk to you about the inherited and non-inherited ataxias in terms of diagnosis and treatment. So I'll do my best. Bear with me. So the first thing to say is, of course, ataxia is a Greek word. Taxis means order. If you put an A in front, then it becomes disorder. And the simplistic view is that the cerebellum, which is the organ involved, coordinates movement. But in fact, it's not that simple, because when you do a movement, you cannot simply rely on a negative feedback control. It's too slow. The cerebellum has to predict the sensory consequences of actions. So this is often called a forward modeling. So forward models transform a set of motor commands into a prediction of their outcome. And the sensory consequences of an executed movement will signal how the movement turned out so that it can then be adjusted. What this means simplistically is that the cerebellum allows you to learn how to do movement. And the learning is not confined to the movement, because we know in the last 10, 15 years or so that there are a lot of cognitive functions that are associated with the cerebellum. Executive function, working memory, mental flexibility, in language, spatial cognition, and even personality changes. And those are things that when we meet a patient with ataxia, so this is a simple classification of ataxias, the one at least I use: genetic, immune-mediated, degenerative, and toxic drug-induced. So ataxias due to structural damage are not going to be included here. So what do we do when we are faced with a patient with ataxia? We look for diagnostic clues, age at onset, rate of progression, whether it's episodic or not, whether it's pure ataxia or additional other symptoms, whether there's speech involvement prominently, and whether there's autonomic dysfunction. And when we examine the patient, we look at eye movements, back of the eyes, we do a head thrust test, look at tremor, if they have one, and other aspects of their mobility that may, again, give us clues as to the etiology of the ataxia. Just to give you an example, this is somebody with a tendon xanthoma. If you see that in the context of a progressive ataxia, then a condition called cerebrodentinous xanthomatosis can be almost readily being diagnosed. I want to take you through this flow chart, which unfortunately is perhaps too small for you to see, but it's just a diagnostic thought of what goes on when we are faced with a patient with ataxia. So we start with this patient, we do brain imaging with MRI, and if you do identify a structural problem, then obviously that you can deal with it. If you can demonstrate evidence of cerebellar dysfunction, whether it's with the imaging showing atrophy or spectroscopic abnormalities, and you can confirm that there's cerebellar involvement, then you can divide into those who have a family history or have early onset ataxia and those who have late onset ataxia. And how does brain imaging help us other than just showing that there is perhaps a bit of atrophy of the cerebellum? Well, there can be features there that can be diagnostic. For example, here you can see increased signal in the cerebellar pita angles that is seen in Fragile X tremor ataxia syndrome, or you can see a hot cross band sign, which is often seen in multisystem atrophy. You might not know what a hot cross band is. It's an Easter cake that is found in the UK. That's why it looks a bit like that. Or here's another example of somebody that I saw recently. There is increased punctate patchy sort of lesions in the pons and the cerebellum, and that's typical of a condition called clippers, which responds very well to steroids. So then moving down the flow chart, you have a family history of ataxia. In the UK now, we do whole genome sequences straight away. So previously we had to look for clues, and still some of the ataxia that cannot be picked up by whole genome sequencing, you might have to think about it, like for example, canvas. If those clues are not there, you might proceed to whole genome sequencing. And also, if everything is negative, you might need to consider muscle biopsy if you are strongly suspecting a mitochondrial problem. And on your right-hand side, the late onset sporadic ataxia, you can do some preliminary blood tests, including some basic screening for gluten sensitivity, for anti-GAD antibodies, paraneoplastic antibodies, inquire about alcohol intake, which is a common cause of ataxia, at least in the UK. And then if all is negative, consider the diagnostic criteria for primary autoimmune cerebellar ataxia, which I'll come to a bit later. Now, in Sheffield, anybody who comes with ataxia and has an MRI scan automatically gets MR spectroscopy. Just very briefly, that allows you to look at 3 spectra. The important ones are the N-acetyl aspartate, which reflects the metabolic activity of the area that you are interested in. So the higher it is, the better it is. And then creatine is a metabolite that doesn't change in health and disease, and therefore the ratio of NA to creatine gives you a numerical value that you can use as diagnostic and monitoring tool. So here's, for example, somebody with gluten ataxia before and after going on a gluten-free diet, and you can see that the N-acetyl aspartate increases following the treatment. If you look at prospectively a group of patients with different types of ataxias, you can show that, for example, in SCA6, which is a slowly progressive ataxia, the decline is very, very slow over many years, whereas in the multisystem atrophy, which is an aggressive degenerative ataxia, that goes down very, very quickly. So you can develop patterns that allow you to monitor and diagnose ataxias. So moving on to causes of ataxia, this is data from our 3,000 consecutive cases of ataxia. 85% had sporadic, 15 had a family history, and 9% of the 3,000 had ataxia that started at the age of 20. And as we know, in that group, the majority have a genetic ataxia, and the commonest, as always, is Friedreich's ataxia, followed by, in this case, episodic ataxia type 2, then ARSAX and ataxia oculomotor apraxia type 2. Now, if you put together all the inherited ataxias, meaning those who have a family history, but also the sporadic ones where we reach a genetic diagnosis, of those, autosomal dominant account for 40%, recessive 16%, and those who have sporadic but were genetically confirmed, 44%. So in the UK, the commonest dominant ataxia is episodic ataxia type 2, followed by SCA6. And the commonest autosomal recessive ataxias in the UK is Friedreich's ataxia, followed by SPG7, and then CANVAS. What about genetic diagnosis in sporadic ataxias? And this is a figure that you might need to remember, that if you do genetic testing in people who haven't got a family history, you can pick up to 12% having a genetic cause. And again, FA leads in that group, followed by CANVAS and SPG7. So if you look at genetic ataxias as a group, then FA in the UK is by far the commonest, episodic ataxia 2, SCA6, SPG7, CANVAS, SCA2, and then the new kid on the block, SCA27B, which is proving to be relatively common. A bit about non-inherited ataxias. This is a Venn diagram showing you the distribution. So the big green section is the genetic ones, and the big blue section are patients with gluten ataxia. And I'm going to talk a little bit about the immune ataxias in general because they are treatable. So the total number of immune-mediated ataxias in our group is 42%, which in fact is more than the genetic ones. And in that group, gluten ataxia leads the way, followed by primary autoimmune cerebellar ataxia, anti-GAD-associated paraneoplastic cerebellar degeneration, and degenerative, by which I mean MSA, C, some of the PSP that can present with ataxia as well. And then toxicity, I refer to alcohol and drug-induced things like phenytoin, which can cause permanent ataxia, and lithium and some other ones. So starting with gluten ataxia, this is sporadic idiopathic ataxia with positive serological markers for gluten sensitivity. We said that is very common. But there is a diagnostic problem, which I suspect most of you will encounter, which is that if you use tests that tell you whether the patient has celiac disease, you will only pick up a third of them, because 2/3 don't have celiac disease, and yet they are positive for the appropriate serological testing, which in this case is anti-gliadin antibodies. And this is a picture from a result on a patient who was referred to Sheffield with an unknown ataxia, and you can see that the endomysium and transglutaminase antibodies are negative, so he hasn't got celiac disease, but he's got very high values for gliadin antibodies, and this person will improve on a strict gluten-free diet. The gluten ataxia patients universally have gait ataxia, and that's because it's primarily a Vermean pathology, and which is a characteristic of a lot of the autoimmune ataxias as well. And we've shown many years ago that if you adopt a strict gluten-free diet, then these patients do very well, provided you make a diagnosis early. And this is a plot of their spectroscopy, NAA to creatine ratio at baseline and following strict gluten-free diet, showing that they all improve with the diet. You can show this typical pattern that those who, sorry, there's a line here that is missing, but those who are strict, don't go on the diet, then they get worse. Those who go on the diet and they are strict improve, and those who go on the diet but they're not 100% strict, they deteriorate but at a slower pace. So you have to be 100% strict. Let's see if we can get this to work.
Okay, and then do the same with this leg.
So this is a patient who came to us acutely from another hospital because he developed ataxia very, very quickly.
Okay. Touch your nose, touch my finger, touch your nose.
So if you see an ataxia that develops like that, it's bound to be immune.
Open your eyes.
You never see it in the context of a genetic ataxia. And this patient had gluten sensitivity. He had raised antibodies to gliadin and TG6 antibodies. So he went straight onto a gluten-free diet. He was also treated with immunosuppression because the diet takes a while to kick in. He was extremely disabled at the time, as you can see.
Okay. Are you able to stand with your feet any closer together? Okay. And close your eyes. Let's take a few steps this way.
And this is him a year later.
So just give us a little bit about you. Tell us about you, Mitali.
Hello, my name's Mitali Cowboy. I live in Stafford. I'm 20 years old. And how much wood could a woodchuck chuck if a woodchuck could chuck wood? How do you think about how I walk?
Yeah. All right.
It's weird.
You don't need to do a catwalk.
So as you can see, a very good recovery because he was diagnosed early. So this concept of primary autoimmune cerebellar ataxia, we developed this with colleagues from various countries who were interested in immune ataxias. And it doesn't project brilliantly, but in essence, what we were saying is that you have an acute or subacute onset of ataxia, predominantly Vermean involvement. The MRI, when you do it, is either normal, or if you have access to spectroscopy, it's abnormal. And then on the right-hand side, you look for trigger factors like gluten sensitivity, cancer, post-infectious cerebellitis. And on the right-hand side, if you have a well-characterized antibody that is associated with ataxia, then you are home and dry and you can treat. But if you don't have any of those, then you look at additional findings such as an active inflammatory CSF or a history of autoimmunity in the patient or a first-degree relative or a presence of antibodies that are not linked necessarily to the ataxia but tell you a bit about any autoimmune diathesis like thyroid antibodies and so forth. You obviously need to exclude other causes of ataxia, and often these patients will have already had a lot of genetics done and so forth. And then you have to think about this primary autoimmune cerebellar ataxia. Why? Because these patients respond to treatment. And here we show a group of patients of ours with PACA, where they improve on the gluten-free diet, and those who don't, improve on immunosuppression with mycophenolate, and those who haven't been treated get worse. And some of these patients are their own controls. So we had data on imaging before they started mycophenolate and after, showing that this is treatable. So we need to be thinking about PACA because it is treatable. And then, of course, there's a lot of other antibodies that are being discovered all along that you can use diagnostically, but unfortunately not all are available readily in the immunology lab. Finally, the concept of cerebellitis, which is a post-infective immune reaction to an infection. I think you need to be careful because some of these cases represent cases with PACA, as is this example of somebody who's got a swollen cerebellum at the onset, very acute, but then if you follow them up, you see that they develop atrophy and become more and more disabled. And by the time you reach this stage here, it's too late to intervene. So the earlier the intervention, the better. Paraneoplastic cerebellar degeneration, this is a reaction to often occult cancer. It's a neurological emergency. If you don't diagnose it quickly and hopefully be able to do something about the cancer, these patients deteriorate extremely fast. This is only a couple of months between the two scans, and you see that how the cerebellum is shrinking rapidly. So my final thoughts are that ataxia is not a diagnosis, but a symptom or a sign. There are many causes: genetic, immune, degenerative, toxic. Some are treatable, particularly immune ataxias, but also some of the genetic ones. I've obviously not spoken much about FA because there's other talks on the subject. But there are other pathways like this cerebrotendinous xanthomatosis, which is a genetic ataxia. There are enzymes you can take that can overcome the problem and treat you. In all ataxias, the earlier the diagnosis, the better the outcome if you have a treatment. A diagnosis can only be achieved by experience gained by regular follow-up, clinical observation, and access to appropriate tests. And a nice example is CANVAS, which is an autosomal recessive ataxia discovered only a couple of years ago. And you know, if you see the patient, you do a head thrust test and it's positive, and they have a sensory ganglionopathy and they have ataxia, you are home and dry. So we diagnose about 40 cases within a year with this condition. And final comment is that only 7% of the 3,000 patients with progressive ataxia remain without a diagnosis. So we have a very good chance nowadays to be precise with the diagnosis. Thank you for the attention.
Thank you, Professor. Thank you for giving us this very live and vivid presentation, and thank you for giving us also examples of how, let's say, the future of other types of ataxia maybe look like, since we saw this great difference in terms of previous, early diagnosis, early engagement on with regards to treatment, and what would be the results, let's say, if an effective treatment is being found in other types of ataxia. So thank you for that. And we have the privilege to have with us Dr. Jörg Schulz, who is a global renowned research and clinical director on ataxia in Aachen University Hospital, Germany, and one of the leading global researchers in terms of ataxia. So Dr. Schulz, he is going to discuss with us today the importance of natural history and biomarker studies in the ataxias. So, Doctor, the floor is yours.
Yes, good morning, and thank you very much for the kind introduction, and to Emily to do all the organizational work. I'm here to represent EFACTS, a consortium that exists since 12 or 13 years, and it was set up by European funding, the predecessor of Horizon 2020 basically, as a research consortium of basic scientists and clinical scientists, and I will talk about the clinical work here. Pukyo, for example, is a representative of the basic scientists. And we founded a registry because we were interested in the natural history of this study, which was not really known at that moment, and because we wanted to investigate which are sensitive scales with which we can measure the progression of the disease, because if you start a clinical trial, if you have a putative protective drug, then you have to compare placebo-treated ones with real treated ones and quantify that. Otherwise, the agencies like the FDA or EMA will not accept the drug. These are the centers that exist now. We started actually originally with 7 centers, and now we have 17 sites in 11 countries. So basically we increased the members, and we also have a site in Greece, which is in Athens. These are the sites and the investigators, and we have Georgios Koutsis in Athens to represent Greece in here. These are the numbers of the registry. You see on the left side that by now we have almost 1,200 patients enrolled and also some controls. This matches well in sex between males and females. And we always argue with a core cohort. These are the first 600 patients that we recruited. That was during the funding period of the European Commission. But you see that after that we continue to enroll new patients, which make up almost half by now. This is the age distribution that we have at the moment. Basically, at the time of recruitment, 192 patients were below the age of 18, and of course they grew older by staying in the registry, so that currently, if you do a cross-sectional analysis, we have 74 patients below the age of 18. This is very important for us because young people are heavily affected. They have a fast disease progression, so we are very interested in recruiting minors. This basically, we can go over this. This shows, we see the patients regularly in monthly visits. There are more than 600 visits in effects per year. And all the patients and the visits helped us to get great knowledge on the natural history of the study. This is shown here as a timeline with key publications, with which some of them I will go into some detail actually. And it created new funding basically for clinical trials. And, for example, funding by FARA in the US for a global imaging study worldwide. This is from our first major publications in Lancet Neurology. On the left one, the first one, in which we showed that the number of GAA expansions is important for the age at onset of the disease, meaning as longer the GAA repeats, particularly the smaller one is, as earlier the disease will start. On the right hand, on the graph with that curve, you see our estimation, how many patients you would need. One line is for a 1-year treatment course, one line is for a 2-year treatment course if you have a protective drug. And then you look at the x-axis below, what treatment effect you estimate from the putative drug, let's say 50% in the middle, and then you go up the line and then you see how many patients for a 1-year or a 2-year trial you will need to show that this 50% protection is protective. And that was done with a so-called ZARA scale, the scale for the assessment and rating of ataxia that is used in most trials in Europe for Friedreich's ataxia and worldwide for all other ataxias. This is now from the 4-year natural history study. You see the study flow on the left side, basically saying that from the initial 600 patients, 366 patients reached the 4-year investigation. And on the right side, you see the different measures that we had, and I'm not sure whether that's working. It is working. This is now for the, I think SARA, because I don't see it on my presentation here. The different lines are in black, all patients. The blue line is early onset patients, and the upper lines are late onset patients. And you see that there is a linear increase over time in these scales, which make them very well suitable for doing clinical trials. And this now hopefully is the ADL, that's activity of daily living, so that's a patient-relevant outcome. It measures whether a patient can dress himself, whether he can do hygiene himself, prepare food himself. And the sensitivity of this scale is almost as good as the SARA scale. So we are frequently asked, what does the SARA scale mean if you lose or if you gain a point there? Gaining points mean deterioration. And now we can say it is meaningful because it directly reflects to the activity of daily livings. So this is a so-called patient-related outcome. And this and the response to the natural history, you saw that early onset accelerates faster, late onset in the disease and being more advanced, the progression is slower actually. This will help us to stratify patients, take the right outcome, and then go from an initial trial with a few patients to a larger trial to see that the medication is effective. For this, also biomarkers are very important. I told you that, and I showed you the line, that you need a lot of patients, 300 to 600 patients sometimes, in a 1-year trial to show effectiveness. If you go to 2 years, it's 200 to 250 patients. But also biomarkers can be very helpful. One biomarker is MR imaging, and we investigated the spinal cord here because Friedreich's ataxia mainly is a spinal cerebellar ataxia with a gross pathology being in the spinal cord and not really in the cerebellum. And we reported that on the left side first, and on the right side you see an international consortium that separated volume of the spinal cord. This is the upper graph versus eccentric figure. So you see on the left side that the myelin normally is round, and in Friedreich's ataxia it's eccentric, so it's more flat. And whereas the volume in the upper graph, the blue one is the control and all 3 others are the patients, is getting smaller, the volume over time, the eccentricity is already there from the beginning and doesn't change much. And that creates the hypothesis that the eccentricity may be inborn already. So patients are already born with that difference, and then the volumes get smaller over time. We also have investigated blood markers. The left graph is from Paola Giunti's lab, comparing different markers in here. And the left upper graph is the one of the neurofilament light chain in serum. You see that most patients have an increase here, and the neurofilament light chain is a marker for the axon of nerves, and you can measure that in the blood. On the right side, it's also neurofilament light chain done in Ludger Schölz's lab in Tübingen. And the lower graph is the controls, and the upper graph is the patients. And you see that in early years, it's a very good marker for patients with Friedreich's ataxia, whereas in the later years, because it increases over time, in the normal control old population, it's not such a good marker. Imaging has been done also in a consortium. It's a meta-analysis of different sites. They are named on the right internationally, and doing a meta-analysis that not only the spinal cord, but also structures in the cerebellum and even in the hemispheres are affected. And that led to the FARA-funded international consortium with sites in Europe, in the US, even in South America, called Track Brain, which measures prospectively markers of brain atrophy with MR imaging, actually including spectroscopy, what you have seen before. And I think I have to talk about it, even it's a sad story that Richard Festenstein, who also is a member of EFACTS, already published in 2014, that treatment with nicotinamide increases frataxin levels. And this is not accomplished by omaveloxolone, for example, that now is on the market in the US and will hopefully come to the market in Europe as well. Omaveloxolone likely is a symptomatic treatment. We need treatments that increase frataxin expression, and this nicotinamide has done in a very small study in 12 patients. And we said now we want to go to a phase 2-3 trial that shows effectiveness in a whole population. We had a huge protocol because our numbers implicated that we need to do a 2-year trial with the different, that's fine now. This is, I didn't see that one was not forwarded, going from the first initial trial of 12 patients to the big phase 2-3 trial with 225 patients. This you cannot read, but it only says at which time point, which investigation should be done over a 2-year time frame, and we had a 2-to-1 randomization, so that double as many patients with Friedreich's ataxia would receive nicotinamide compared to the control group. We had funding for this, which was substantial. We published the protocol already in 2019, but we have huge difficulties to get it running because of legal difficulties in our clinical trial center in Aachen, which needs to do monitoring and pharmacovigilance, actually. And at the end, the funding agency said we needed too long time to get it established and cut the funding. So we have no money at the moment to run the trial. On the other hand, it now becomes difficult also because many patients now will go onto omaveloxolone likely, and then we have part of the population treated with omaveloxolone, part is not treated, and then we do not know whether the differences we see is affected to the one or the other drug. And secondly, both have a kind of a liver toxicity, so liver enzymes are going up. So we actually do not know whether omaveloxolone and nicotinamide are suitable to be taken together. This is also a message to you because I know that some Friedreich's ataxia patients are taking nicotinamide. Be very careful if you add omaveloxolone to that because we do not really know whether that is possible and a good idea. So at the end, I would like to thank you for your attendance here, listening to me, but of course to all Friedreich's ataxia patients that are participants in the registry and also to their families. I thank all local PIs who are doing wonderful work. And I thank Miriam, who was the coordinator for EFACTS for a long time. Now at my side, Claire Ditzun and Jennifer Michels have taken some of the duties. And thank you very much.
Thank you, Doctor. Thank you for giving us the idea why we, as patient organizations and the families, why we need to take all this each and every semester or each and every year to take our kids or ourselves, if we are patients, to clinical centers, because actually these annually tests do matter. It have an impact. It feeds the natural history, which is very important in terms of designing future clinical trials and giving, let's say, something to compare on with regards to treatment. So you also touched topics with regard to the nicotinamide trial. I know that in Europe it was in discussion the last years on that, and thank you for sharing this information with our associations. Without further ado, I will introduce Dr. Miriam Rai. I don't think that Miriam needs introduction. She's the Director of Global Patient Engagement at US FARA and a very good friend of the European Friedreich's Ataxia community. So Miriam, thank you for all these years that you have devoted to starting with Massimo Pandolfo and moving on to the US FARA for all these years. So Miriam will present the pipeline, and I think that this is a very touchy point on this discussion. And then we have Dr. Barbara Boroni online, and we will have some time for questions also.
Thank you, Vasilis. Well, I would like to start thanking actually Ataxia, that was too quick, thanking Ataxia for their continued commitment to advancing research in the ataxia field, but also to thank Ataxia for not only inviting FARA to present at Ataxia meetings. FARA was present at previous Ataxia meetings, but also to collaborating actually with FARA, to sharing resources, taking and giving advices. So that's very important to FARA, and I want to just to enhance it this morning. No. Okay. Yes. So what I have been asked to present this morning is the Friedreich's Ataxia treatment pipeline update. And obviously, I need to start this with bringing up the Skyclarys story. As you may know, the FA community had this year the first approved treatment for Friedreich's ataxia, being Skyclarys by Reata. And what I would like to enhance there is that FARA has contributed to the Skyclarys story since the beginning. So FARA has funded actually basic science research since many years on the target of the Skyclarys, being the NRF2. And FARA has participated also and discussed how to design the clinical trial. Natural history studies, similar to EFACS, FACOMS in the US, has informed the clinical trial design. And most of it, the patient voice and the patient engagement was heard in designing the Reata trials, but also in understanding the meaningfulness of the result to the patient. What a progression being slowed by the treatment means to the patient. And maybe this is a good story actually to understand how the patient advocacy groups' contribution to clinical trial and to partner with industry is important to advance the research. And the work has not finished actually, it's only a start with this approval of the first medication for FA in the USA. And what FARA continues to do, FARA continues to advocate actually for Reata, first to address the access questions and needs of the global community. So Skyclarys is available in the USA, will probably be available in Europe next year. This is what Reata has declared in their latest press release two weeks ago. But more importantly, the global community of FA is wider than US and EU. And FARA continues to advocate to that. We also continue to advocate to initiate the pediatric studies as soon as possible. Skyclarys being approved for adults, young adults, 16 years and above. And pediatric studies will obviously start in the coming months, maybe at the last quarter of this year, if not early 2024, in the USA and in Europe. And we also continue to advocate actually to provide updates to the FA community, because clinicians can update and inform the FA community about the results, about the advances, but when the industry comes and speaks about the result, about their effort, about engagement in lay language that you would all understand, that's important. And also to address the recurring questions on the previous 2 points I explained. So what else is in the pipeline? What else? Because ideally, we have one treatment, but we would like to have multiple treatments to address the various targets and various levels of the Friedreich ataxia, from the gene silencing by maybe gene editing therapy, to the protein level, to the cellular level, and last but not least, to the symptoms level. So ideally, we will have a combination of all possible treatments acting on the blue boxes that will affect the red boxes being the causes and the result of the frataxin deficiency. And here on the pipeline, I'm just going to highlight few programs, the most advanced ones. From PTC Therapeutics in red, you can see the vatiquinone clinical trial. This is a phase 3 trial that is almost completed. I believe the last visit are being completed now. The results are expected during the end of this year. And we hope, if the results will be positive, and this is an engagement of the industry partner, to have approval in EU and in US for the treatment, again, if the results will show a positive benefit. And what is also good in this program, if it will be successful, is that the trial has been designed and included children and young adults as well. Two other programs that I will highlight that are in earlier phases, the Larimar Therapeutics program being the frataxin replacement therapy. It's an early phase 2 currently, has dosed during 28 days with multiple groups already. The results are being discussed. And the next phase will be to dose a higher dose of this frataxin replacement therapy. And if all go well, Larimar is engaged actually to run a global clinical trial, phase 3, in Europe also, and probably in young adults, if not children. Design Therapeutics is it has an activator DT216. That's a small molecule that will reactivate the transcription of the frataxin gene. They are currently dosing the multiple ascending dose studies in small groups for safety. And Larimar is the same. I haven't mentioned that. So Larimar and Design Therapeutics are at the safety level of their clinical development. And if all goes well, also they intend actually to deploy a global clinical trial for a later phase 3 if all the steps will be successful until then. And last but not least, we have in orange the gene therapy. Unfortunately, gene therapy in Friedreich ataxia has been shown to be more complicated than expected. Many programs have stopped. Other programs are still developing. Frataxin toxicity was probably an issue, and it's good that those programs have shown this toxicity. So the balance with how much frataxin is okay without being too much is being more fine-tuned and studied. We don't expect any nervous system gene therapy clinical program before 2024, if not later. There is currently one gene therapy addressing the cardiomyopathy in FA being conducted by the industry partner Lexeo and also investigator-initiated at Cornell in New York. And they are they recruited, probably dosed a couple of patients, and we will see the outcome of this early phase gene therapy for FA. So what's next for the FA horizon? Global clinical trials will be probably the horizon for FA from now on, but what does that need? That needs to be supported actually by sites and by initiatives in various countries. More education is needed to the community to understand why so many programs and why the programs are slow to the FA community timescale. And also the need to promote clinical sites with FA expertise to bring those to the industry partners and make them more known. And what we are doing actually to support this, one initiative FERA has started this year is the Friedreich ataxia Global Clinical Consortium. That's actually that's not reinventing anything, that's only harmonizing and merging the EFACTS efforts that Professor Schulz has presented and a similar effort that has existed in the US, Australia, and India that FA comes, but by having this global consortium, we hope that we will provide more clinical sites readiness and visibility to the industry partners, but also to the regulators. And another item is education. We have actually created during end of last year a clinical trials guide to explain in a lay language all the steps for clinical trials that FERA is happy to share with the Ataxia members. We have already translated to various European languages, and I'm happy to discuss this with the individual association later. And another piece of education important is actually to engage more the industry partners, how to engage with the patients. From the early phases of development to know FA, to know the community, but also to listen to the patient voice once more in designing the trial, and also after the trial to follow through the patient's community, to come with thank you notes, with explanation on the results, and to manage the expectations as well. So as you see, the work has not finished. We are continuing our collaborative work. I would like just to add on a side note, for all these resources, we are happy to work all together, and more importantly, in the FAGCC, we do have in the governance structure a working group deducted only for patient advocacy advisory group, and there probably some association from you have already heard, and we will take the discussion later on that. Thank you. And with that, I will lead it to the next speaker online, and we'll take questions at the end.
Thank you, Miriam. Thank you for giving us an update on the pipeline. I think that all the associations, parents, and our partners are very familiar with this tool, and it is a very visual tool where we are heading. And of course, when you see lines, you think that this is simple to get the line ahead, but it has a tremendous effort and a lot of work that has been done on the backbone in order to promote future treatments. So we as associations, we need to cooperate on that. Probably the new GCC is a great tool that accommodates all the health data under a single and simple umbrella, which is probably very, very important in terms of having the data available for our partners. So, okay, we will take questions too at the end. Thank you. So without further ado, I would like to introduce and welcome to our conference Dr. Barbara Boroni from University of Brescia. Welcome, Doctor. And Dr. Boroni is going to discuss on potential value of transcranial stimulation for symptoms relief in ataxia. So if we can have Dr. Boroni on the screen, I can see her in my small laptop, but we can't see her in the big screen. So if we can do that, and we are good.
Well, I really thank indeed the organizing committee, chairperson, and in particular Emily Cutting for kind invitation. Okay. Well, my talk today is on non-invasive stimulation in cerebellar ataxia. Well, the final goal of our research, from basic science to clinical trials, is to find out a beneficial treatments for our patients with cerebellar disorders. And in this context, we may indeed pursue two different strategies. On one hand, we need a specific treatment for pathogenetic mechanism for each cerebellar ataxia, and this is undoubtedly the best approach to slow down disease progression. However, this approach may be hampered by heterogeneity of cerebellar ataxias, and in this sense, we need a proper treatment for each disease. On the other hand, we may think to enhance cerebellar function independently of pathogenetic mechanism. And in this view, the field of non-invasive brain techniques and brain stimulation has recently gained much attention in scientific community and also in patients with cerebellar disorders, in particular because these techniques are non-invasive. And in this brief, in the other talk, I would like to show you two different approaches when we talk about cerebellar stimulation. And these are transcranial magnetic stimulation and transcranial electrical stimulation. And I would like to answer three different questions and unmet issues. Well, first of all, is transcranial stimulation effective in cerebellar ataxias? The second question is, which transcranial stimulation approach might show greater benefit as compared to others? And the third question is, should we think about different settings to ameliorate compliance and patient comforts when we talk about transcranial stimulation approaches? The first approach I mentioned is transcranial magnetic stimulation. TMS is a stimulation treatment that uses electromagnetic induction, which turns to electrical stimulation to indeed stimulate specific part of the brain. This technique is non-invasive, is painless, is free from strict exclusion criteria. We can indeed do it in a patient with epilepsy or metal implants, and is safe. But as you can see here in the picture, well, the device is quite sophisticated, and indeed we can do it only in hospital setting, and we need expert personnel and dedicated personnel to carry out this kind of session. Each session lasts only a few minutes, and this is good. But as in all in the transcranial stimulation technique, we need multiple sessions to have long-lasting effects. So we can do it only one day, but we need in the stimulate section for at least 2 weeks or 3 weeks. In this slide, you can see the list of different studies suggesting the usefulness of transcranial magnetic stimulation in patients with cerebellar ataxia. I don't want to go in deep in that, but just to say that the first study demonstrated the possible effectiveness of transcranial magnetic stimulation date back in 1999. It was carried out only on 4 patients with spinocerebellar ataxia type 1. And as you can see here, the treatment was done every day for 21 days, so for a long time. And the authors show a reduction of a time for a 10-meter walks. The same authors extended the study on and included 74 patients, both with genetic ataxia and sporadic ataxia, once again for 21-day treatments, and they demonstrated improvement of gait, speed, and standing capacities. Well, different studies have been done over years. The last one is a well-done study on 20 patients with ataxia, and once again, the authors demonstrated improvement on motor symptoms. It's difficult to compare different studies because of different protocols, but the literature we have suggests that there is some benefits of transcranial magnetic stimulation in patients with cerebellar ataxia. The other type of approach is transcranial electrical stimulation. Once again, the stimulation treatment uses electrical currents, low amplitude electrical currents, to stimulate specific part of the brain. Once again, we have non-invasive procedure, painless, free from strict exclusion criteria, and this approach is safe. But the main difference as compared to transcranial magnetic stimulation is that this approach, this device is easy to apply, is portable, and this is the main difference to me. But once again, we need multiple sessions to have long-lasting effect. In this case, we may have different procedures, different approaches for the time of current delivered to over the cerebellum. As you can see here in the slide, we may have a transcranial direct current stimulation with, continuous current. We may have a transcranial alternate stimulation. And in this case, we deliver sinusoidal type of current. And the third one is transcranial random noise stimulation. These different techniques may have different mechanisms. I don't want to go in deep into that. But indeed, up to now, the study available in the literature have been done with using transcranial direct current stimulation. How can we do that? Well, you usually do two different electrodes. One placed over the cerebellum, and this is the stimulating electrodes, and the reference electrode over, the right shoulder or the spinal cord. Once again, we have different studies. Some studies demonstrated that transcranial electrical stimulation is beneficial in improving in their motor symptoms. Other studies did not demonstrate a significant difference as compared to placebo stimulation, but all the studies demonstrated safeness and the lack of significant exclusion criteria. What I would like to show you today is our study. Well, it was carried out on 60-ish patients with cerebellar ataxia, with different kind of the type of ataxia disorders, and our approach was in the one shown in the slides with stimulating electrodes placed over the cerebellum and the reference over the spinal cord. We demonstrated also that this approach specifically indeed involve cerebellum, as you can see here in the upper right part of the slide. And this is indeed our study design. We divided randomly our patients in two different groups. The group one received the placebo sham stimulation for 5 days a week for 2 weeks. And then after 3 months, a run of real stimulation, multi-session real stimulation. The group number 2 received 2 runs of real stimulation, both at baseline and after 3 months. And this is indeed the proper way to demonstrate if a treatment may be effective in cerebellar disorders. This is quite complicated, but as you can see here, we measure indeed motor impairment. And, the lower the scores, the better the performance. And as you can see here, after real stimulation, after real transcranial direct current stimulation, there was an improvement both time of motor impairment. And what we can say by these slide is that in the 2 multi-session TDCS are better than 1 in improving motor symptoms. The same results were obtained when we considered the quality of life of our patient. And the other thing we demonstrated is that transcranial direct current stimulation was able to improve cerebellar connectivity. We can measure the cerebellar connectivity. To make a long story short, this is what we may find in a subject with no cerebellar symptoms. And this second line in this is a picture of cerebellar connectivity in patients with cerebellar ataxia. When the device is switched off and we deliver placebo stimulation, as you can see, there is no change in cerebellar connectivity. In the picture below, the baseline is the same, but when the device is switched on and we deliver real transcranial direct stimulation, there is a restoring of cerebellar connectivity, and this is maintained at follow-up as well. So we demonstrated that TDCS, transcranial direct stimulation, may be effective in our patient with cerebellar ataxia. But the second question I would like to answer with you today is, which is the best treatment or best approach? As I told before, all the studies we have had been carried out with transcranial direct current stimulation. We wanted to compare two different techniques to propose, the best treatment to our patient. And we compare the transcranial direct current stimulation, the previous one, with transcranial alternate current stimulation. We use also in there the wearable sensor to measure turn velocity, gait cadence beyond in the neurological examination. And as you can see here in this slide, when in the gray column, we may report in the no improvement when the device is switched off. In the red column, you can see the improvement in turn velocity and in gait cadence, and also in motor scores, conventional motor scores, after transcranial direct current stimulation. And in blue column, you can see, the improvement after transcranial alternate current stimulation. We thought that this study was important to, choose the best device and the best option for our patient. What we can say is that both treatment, both approach are usefulness, but indeed TDCS may be better as compared to transcranial alternate current stimulation. And I know that you are familiar with this task. As you can see here, before pre-stimulation and after stimulation, there was a clear improvement of symptoms. The last question I would like to answer about is to ameliorate comfort and the benefit for our patient when we talk about transcranial stimulation. As I told before, we need multi-session for 2 or 3 weeks at least to have long-lasting benefits, and this is demanding for our patient. There is a case report of an Italian group where they carry out transcranial direct stimulation in a patient with cerebellar ataxia at home. And the final goal of our research now. We did the same in another pathology. Well, in Alzheimer's disease is completely different, but just to say that we have had a good feedback from our patient. We may remotely control in each session the effectiveness of each section by these control. And indeed, by video calls, we may also monitor if, the electrodes are placed in a right way and everything is okay for our patients. This is quite important for us, indeed, because also in neurodegenerative disorders in general, in the comfort and in the safeness as well are quite important. So just to compare and just to conclude about these kind of approaches for transcranial stimulation, both transcranial magnetic stimulation and transcranial electrical stimulation, both TDCS and TAX, are free from significant side effects, are free from strict exclusion criteria, both are non-invasive. Transcranial electrical stimulation is easy to perform as compared to transcranial magnetic stimulation, and most importantly, is portable in at-home setting. Well, if we need to compare indeed both these techniques by a clinical impact point of view, TMS has usually a stronger clinical effect. To sum up, transcranial stimulation has shown promising results in improving clinical symptoms But we need further studies, to investigate in the homogeneous cohort to understand if indeed we may suggest this kind of approach in patients with different types of ataxia. We need to optimize treatment protocols, the number of days, the different sections, and the times between different sections, and follow up. Well, we may also investigate the add-on effect of transcranial stimulation with other treatment or training. And last but not least, I believe that it's quite important to move from in-hospital setting to at-home setting, proving efficacy also in multinational cohorts. Before concluding, I would like to thank all the collaborators, Ataxia UK for the support, and I thank you all for your attention.
Thank you, Doctor. Although we are off the schedule for 10 minutes, I think that we have time to take some questions to Professor Hadjivasiliou, Professor Schultz, Dr. Miriam Rai, Dr. Boroni. So please feel free to ask something to our panels, and if I will start with a question, just to break, let's say, the silence. So, and I'm looking to Dr. Schultz and Professor Hadjivasiliou. How important is, in terms of clinical research and in terms of your daily engagement with the patients, their effort that they are doing on coming to you and get their tests? Because sometimes we see as patient advocates that for many of our patients this is a challenge. So if we want, let's say, to have results, and if we want to have more accurate data, how we can assist you on this journey, both the patients and the senders?
I think I get started and you can contribute then. I think it's of uttermost importance because everything I presented here is immediately depending on what you are saying. And that is also why I thanked the community for doing it. Otherwise, we wouldn't be able to design studies that Miriam, for example, explained, to have the right outcome markers, that we really have in a short period of time the best answer. On the other hand, and certainly similar in Sheffield, I mean, the advantage the patients have is that they get the best possible treatment at the time. So, for example, in Friedreich's ataxia, we also send them to our cardiac department, that also the heart is followed up. And once there are news, omaveloxolone treatment or something like that, of course, they get it as well, and they can enroll in clinical studies as well.
I guess the difficulty is the geographical aspect of things and getting patients to come from very far to be assessed on a regular basis. But in practice, it's amazing that people are just extremely dedicated and they're willing to come. I think in our center is also helped by having a group of ataxia nurses who are often very good at liaising with the patient between appointments and addressing other issues that don't require physical attendance. So a combination of the two works extremely well in our hands.
Thank you. Our guests. No questions? Dr. Boroni? No questions? Dr. Boroni, this technology is for all types of ataxia or for some types of ataxia?
Well, as previously said, we need to demonstrate the usefulness in a larger cohort with different types of ataxia. From our experience, we tested it in spinocerebellar ataxia, in sporadic ataxia, and in multisystem atrophy, and it seems to work in each kind of ataxia disorder.
Okay, thank you.
But we tested it on a small sample of subjects, so we need larger cohorts.
Sure.
Thank you all for some very nice talks. I want to ask Dr. Schultz and Professor Hadjivasiliou something which I hope won't embarrass them about the presentation of Dr. Baroni, and wondering how you feel about the translation of her research into the clinical environment, and whether it is possible for you to facilitate what she believes is the preferred option of people doing it at home.
We are always open-minded and always looking for anything that is likely to benefit our patients. In Sheffield, we just bought a new transcranial magnetic stimulator. I was interested in looking at whether or not it's capable of distinguishing between immune and non-immune ataxias in terms of certain measurements that you can do. But no, I think this is very encouraging. I think it's a matter of setting up a new service. You need to prove that it's cost effective. And as you know, in the UK, the NHS does take time, but when there is a will, there is a way. So we certainly pursue it.
Yeah, I completely agree to that, but it's early days, one also has to say. We do not know much about the long-term effects. How long will the effect stay? How frequently can you repeat it? Is it able to sustain the effect? But you're absolutely right. I mean, that's what we are doing. I mean, we are doing translational research, and if we find something that is working, we have to implement it to daily practice.
Sorry, if I might come back. I wasn't really asking a question about the science. I'm not competent to ask that. I'm really asking more about the practicality from the patient's position, as to whether you as clinicians think that within your respective medical systems, you can press for this to happen, should the science ultimately prove to be really effective.
Yes, it's the answer.
Depends on the effect. I mean, if the effect is very good, we will do it.
Any other question? Yes, please.
A question for Dr. Baroni. So, what do you think is the mechanism of the intervention? It sounds a little bit like reboosting a computer and suddenly seems to be working when it's not working before. I guess it's more scientific than that. Yeah,
well, we do not know the mechanism in that, but different techniques may have different mechanisms. For instance, transcranial direct stimulation may enhance cerebellar plasticity, while transcranial alternate current stimulation may entrain in the Purkinje and cerebellar in the firing. Also, when we talk about indeed mechanism, we need to study further in different techniques, but not only for cerebellar disorders, but for neurodegenerative disorder in general.
I have a question to you, Professor Hadjivasiliou. You talked about the differential diagnosis of ataxias and having the hereditary ataxias on the one side, the sporadic ones on the other side, for which you find many autoimmune causes. Could it also explain the variability in hereditary diseases? I mean, we know that VA expansions and so on, they determine some of the disease, but by far not all of the variability. So my question is, have you specifically looked for autoimmune causes in genetically defined patients? So does that contribute?
Yes, is the answer. So when we do the testing, everybody will have everything done. And of course, inevitably, you might find patients with a genetic ataxia who, for example, are also gluten sensitive. And then in that situation, we discuss the finding of gluten sensitivity with that patient and just say, well, you know, in this situation, gluten-free diet can be helpful, particularly if they have gastrointestinal symptoms and so forth. And a lot of them end up going on the gluten-free diet, but the results are very mixed. So you might find that some patients with FA, for example, who are gluten sensitive, seem to improve for a period of time. Eventually, if you follow them up, you see that the trajectory is still going downhill because it's a genetic determinant, but it's a situation where you have two contributors, if you like.
Yes.
Hi, it's Paola. Marius, one question for you. For celiac ataxia, do you think that you are satisfied only to have a raise of antibodies in the plasma, or you go for the antibodies levels as well on the CSF? Because we have so many, it's so variable, and the expression in it, it's very variable from gut, from peripheral neuropathy, headaches, etc. So how specific we should be in the diagnosis? Thank you.
Thanks, Paola. Good question. So there's a range of antibodies, as I said. So you have transglutaminase and endomycin, which in fact look at the same antigen, which is transglutaminase 2. And those tell you whether somebody has celiac disease. In the anti-gliadin antibodies, which are antibodies against gluten, which is what's found in wheat, barley, and rye, are antibodies to an external stimulus, if you like. And you shouldn't have them if you are not sensitive to gluten. So gliadin antibodies tell you that the patient might be sensitive to gluten. But going back to the issue of the pathogenesis, you may have heard of TG6 antibodies. So there are different transglutaminase antibodies. There's TG2, TG3, which is an epidermal transglutaminase, and TG6, which is a brain-expressed transglutaminase. And depending on what your immunological response targets, then it depends what your manifestations might be. So we've shown, for example, that our patients with gluten ataxia have antibodies against TG6, which is a brain-expressed transglutaminase, and therefore those are the ones who are more likely to develop neurological manifestations. As regards the CSF, we're doing currently work with a PhD student looking at CSF of these patients, and you can show that they have TG6 antibodies in their CSF.
Thank you, Professor Hadjivassiliou, Dr. Schultz, Dr. Rai, Dr. Boroni. And before we break up, I will kindly invite you to come along and have a family photo all together, and then you can enjoy the break. I think it was a good start of the day, a very heavy one. We are okay a little bit later of the program, but we will catch up later. Thank you to our panelists.